Good morning, everyone. Welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is Managing Medicare Advantage. PYA is happy to present today's webinar on this important topic. Before we get started with the webinar, I'd like to go over a few housekeeping items. As this event is for CPE credit, there are some additional steps that we will take in order to comply with NASPA's requests. Attendees will be provided 3 polling questions throughout today's webinar. Responses are documented electronically. Attendees must respond to these polling questions within the allotted time to receive CPE credit for this course. A post-event survey will also be provided for attendees to submit regarding their webinar experience. The polling questions and the post-event survey must be submitted for proof of participation today. You may submit questions during the webinar by typing a message into the question pane of the control panel. Also, immediately following the end of the webinar, you will be asked to complete a short survey and submit any additional questions. We will respond to questions posed after the webinar by email. We have posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you will receive an email later with a copy of the slides and a recording of the webinar. With that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Thank you, Laura. Good morning, all, and let's just jump right in. We're going to start with a survey of the state of the Medicare Advantage program. We're going to take a deep dive into prior authorization and related issues there, and then talk about some of the recently published regulations, including the 25 rate announcement and now the 25 final rule, to bring us up to speed on what's going on with the Medicare Advantage program. The risk of listening on a webinar presented by 2 old ladies is that we always want to provide a history lesson when it comes to the Medicare program. Kathy and I still occasionally say HCFA as opposed to CMS, and we were definitely around for the debate over what was first Medicare plus choice. So the original Medicare program, traditional Medicare, the government plays 2 roles. It's the payer, which is the deep pocket from which the dollars come to pay for healthcare services, as well as the processor. It is responsible for either directly or by contract establishing processes to pay claims for services furnished to Medicare beneficiaries. So it plays both roles. In 1997, there had been much conversation around bringing the efficiency and cost savings that have been realized in the private sector through managed care plans to the Medicare program. So effectively, the government giving up its role as processor and handing that over to these private insurance companies. And that was this framework that began as Medicare plus choice with the BBA in 1997. 6 years later, and what is the long name, Medicare Prescription Drug Improvement and Modernization Act, that rolls off the tongue, which everyone now calls MMA. In 2003, the main piece of that legislation that caught everyone's attention was the creation of Part D, which is the prescription drug benefit, but it also modernized the Medicare Plus Choice program into what we now know and love today as the Medicare Advantage program. Interestingly,
no might be the correct word. I'm not sure about love.
Well, for today. I knew you'd do that. But what's interesting is as impactful as this program is, we really have not seen any significant legislation addressing the MA program in over 20 years. So we're going to talk about some of the issues that have arisen in the program, what CMS is doing in its role regulating the program. It actually has very broad legislative authority to regulate MA plans. It is typically stepped back because CMS says the idea behind this program was that we were going to bring the efficiencies and cost savings of private industry, and we're not in a position to regulate those relationships. So that is part of what's created the program that we have today. let's talk just the basics. Get sort of some groundwork on what plans have to do and what plans can do. Plan is required to cover the same services as traditional Medicare. So if there's a benefit in traditional Medicare for a beneficiary, they should be able to receive the same service, same goods as they would receive under traditional Medicare. MA plans have to comply with beneficiary maximum out-of-pocket limits, my personal favorite acronym in Medicare, the MOOP, which for this year is just under $9,000. It's adjusted each year for inflation. Keep in mind, one of the big selling points of MA plans is that you have a maximum out-of-pocket limit, there's some predictability to what it will cost to provide health insurance coverage for you. But keep in mind, the MOOP does not include the required Part B premium. Even though you're enrolled in Medicare Part C, beneficiaries still have to pay the Part B premium each month, which is that $174, which of course, the base is $174 this year, but it's higher depending on income.
And remember that under MA, you have to have B. You have to buy B. Whereas fee-for-service Medicare, if you don't want B, you don't get B. Granted, that's not a wise choice, but you don't have to do it.
Which creates all sorts of interesting issues, doesn't it, Kathy? Because a lot of the metrics we use to determine pricing and payments in the MA plan are actually based on Medicare fee-for-service, which we have a population in Medicare fee-for-service that doesn't have Part B.
Exactly.
It's sort of an apples to oranges comparison for some purposes. The other thing, the other uncontrolled out-of-pocket expense, if you are in an MA plan, is any non-emergency out-of-network services that you receive. Most MA plans, and there's variations certainly within MA structures, but most MA plans do not provide benefit when you receive services as a beneficiary, non-emergency services from an out-of-network provider. So if you make that election, that amount you pay out of pocket is not counting against the MOOP. The MOOP is literally just what you're paying within your covered benefit under your plan. MA plans have to meet network adequacy requirements. So they have to make sure that if they're going to operate in a particular county, they have to meet prescribed rules from CMS as to the adequacy of primary care, specialists, behavioral health services, hospital services, and the like. Certainly some exceptions that apply to those network adequacy in rural areas, which have been one of the limiting factors in the growth of MA in rural areas. MA plans must reimburse non-contracted providers at least the amount payable under traditional Medicare for Medicare covered emergency services. So if it's an emergency, the MA plan is going to cover that service. So if you have to go to the hospital and you can't get to your network hospital, you go to the non-contracting hospital and those services are provided to you. The MA plan is responsible for paying that hospital at least as much as that hospital would have been paid under the traditional Medicare program. Now that's easy if you think it's just a fee-for-service rate, but remember we've got outlier payments and negative and positive adjustments for quality scores and meaningful use and quality reporting adjustments. All of those apply in determining what exactly your payment is as an individual provider within the Medicare program. And also an issue that has been front and center for rural providers is reimbursement for critical access hospitals that receive cost-based reimbursement, and whether MA plans are always appropriately paying at those rates. If you are a non-contracted provider and you want to challenge the amount that you receive from an MA plan for providing emergency services, there is a vehicle to appeal the plan decision, but as part of that appeal process, you are required to sign a waiver of liability to the MA plan. So there is a vehicle for appealing improper payments if you believe it's an improper payment, but appreciate that it's going to limit your liability going forward.
It's important, I think, to raise that, Marty, because we've had so much education on No Surprises Act, the independent dispute resolution process. We've got to recognize these products, these plans are not subject to that.
Right, exactly. You go, this is your route. If it's an MA plan, that's the payer. MA plans must also provide enrollees an appeal process consistent with specific regulatory requirements, which include multiple levels of review. So if a plan takes an action that adversely affects an enrollee, such as denies an admission to a skilled nursing facility, there's a very specific process the enrollee can follow to appeal that decision. And again, it goes up multiple levels of review. And oftentimes as providers, we piggyback onto those enrollee rights in an attempt to get appropriate payment for the services that we provide. Now, on the flip side, MA plans have a great deal of flexibility in how they structure their program. First, they can provide supplemental benefits. So they have to provide what Medicaid, they have to cover what Medicare covers, but then they can also provide beneficiaries with additional benefits to attract them to their program. And this could be dental, vision, hearing, fitness programs. Everybody gets Fitbit, right, Kathy? Everybody gets Fitbit. But as well as food and nutrition programs. So these are generally part of how MA plans market themselves. They provide these supplemental benefits. This is a big attraction in the Medicare population to MA plans to get these additional, what would otherwise be out-of-pocket expenditures for these beneficiaries. Also, since 2020, Medicare plans have been able to offer chronically ill patients supplemental benefits that focus on primarily social determinants of health. So these are non-medical services. Instead, there'll be transportation, housing assistance, and the like that are offered by MA plans to help manage those supplemental benefits. What's critical here, why this is important for MA plans, is that the MLR, medical loss ratio, requires that for every dollar an MA plan receives, it has to spend 85 cents of that on clinical services and quality of care administration. The other 15% is administration and overhead and profit. When CMS permits you to provide these supplemental benefits,
Martie,
they're included in the 80. Yeah, I'm sorry, Kathy.
You said clinical care, 85% on clinical care.
Right. Plus quality of care, quality of
Right.
clinical services and quality of care.
Which could be the supplemental benefits
Right.
as well,
Exactly.
like Fitbits.
Right, that's included in the 85. Right. And if they don't spend 85 cents of the dollars, they end up paying rebates back to CMS. So MA plans are very concerned about their maintenance of MLR. And what's critical here is when we treat these supplemental benefits as part of the MLR, that means that they're using those expenditures as the equivalent of clinical care. Plans, as many of you well know, can pay network providers negotiated rates that are lower than traditional Medicare. There is no floor under which an MA plan may not negotiate with a provider, excuse me. MA plans certainly, as you know, can require prior authorization for specified non-emergency services. They can adopt, and we'll talk about changes in regulations that have impacted the prior authorization process. As part of their negotiations with providers, they can include grievance and appeal processes for the provider. So the enrollee has guaranteed appeal processes by regulation, but for a provider, you're typically going to end up negotiating that appeals process as part of your contracting with the MA plan. And finally, a plan can refuse to pay its own network providers for services that are actually furnished by the plan itself. Remember, the plan has to cover Medicare required benefits, but it doesn't always have to pay a provider who furnishes those benefits. And this has become an issue, particularly with the expansion in Medicare of care management services and reimbursement under the fee schedule for care management services. CMS has taken the position that an MA plan, if it in fact is providing an equivalent service as part of its benefit packages to a beneficiary, it is not obligated to pay a provider who furnishes that service. Well, the MA program, has grown incredibly in the last decade. You can see these are graphs from KFF comparing the percentage penetration by state between 2013 and 2023. And then you can see the same by county now in 2023. And as you'll appreciate, the lighter blue is the lowest levels of penetration. Obviously, more in the rural areas, you typically see lower rates of penetration. That's not always true. Look at the state of Alabama, which is a very rural state, very, very high concentration of MA in Alabama. And so we are seeing this rapid growth from urban areas now to expand Medicare Advantage into rural areas. So we're seeing more counties that have a higher number of MA plans that are available for beneficiaries who reside in those counties. And the reason that MA plans are very interested in expanding their beneficiaries is the gross margins that these companies can make on MA. Again, KFF analysis between 2018 and 2021, the gross margin depending on the type of product. And you'll see the blue bar, which is Medicare Advantage, is significantly higher than the other lines of business for these insurance companies. So the significant incentive for MA plans to continue to grow their population. Where we are today, in December of 2023 is the most recent official data that we have from CMS on the on MA penetration. I think it's running, I wrote it down. I'm going to make sure 48.8% MA penetration. You'll hear news reports that it's above 50%, at least the official numbers from CMS say it's still under at 48.8. And in fact, that includes more than MA. That's any non-traditional Medicare enrollee. So that's also going to include PACE and other products of a similar nature that are beyond just what MA offers. So that's where it stands today. Kathy, you want to talk about what our friends at MedPAC told us of their thoughts on MA in their most recent report?
I'd love to, if we had time, I'd love to read a transcript to you because there has been some, I mean, I've been following the Medicare Payment Advisory Commission for a number of years. I think their discussions are great. There was actually a discussion earlier this year on the draft report that I'm going to review right now, where it got kind of vocal. In terms of, I know you don't like MA, but that kind of thing. It was this great dialogue back and forth between the commissioners. So some excitement, even if you're only reading a transcript. But on March 15th, they published MedPAC's March report to Congress. And this is pretty much the rule that addresses what kind of payment rates should we be having for inpatient and outpatient, et cetera. But they included a status report as required by their, mandated by Congress on Medicare Advantage. And one of the things that very open right there, first paragraph, when you start reading the status report, is that the commission does strongly support the inclusion of private plans in Medicare. That's statement number one. Yes, we want private plans, but the concern is what we have now really the appropriate tool? MedPAC in their report said that they believe that 22% more is spent for MA enrollees than for those same enrollees if they were in Medicare fee-for-service. That's $83 billion this year alone. $83 billion. Granted, and that Marty has already addressed the fact that some of this is due to the supplemental benefits that the plans received that fee-for-service Medicare patient did not receive, and better financial protection in terms of perhaps having lower out-of-pockets, that kind of thing. Recognize that when we started this idea of managed Medicare, the rates were set at 95% of fee-for-service. We are now at 122% of fee-for-service. The idea of the 95% was by managing the care of the enrollee, we were going to have lower costs. But we are spending 122% of fee-for-service. The wrap up to the MA report basically from MedPAC essentially said we need to have a major overhaul. We need to go through this in great detail and really start looking at all of the various components. So MedPAC will be doing that over the next couple of years, and they pretty much started with looking at two issues. They have a second report in this year's update that really looks at how can we better assess coding and selection and the impact that that is having on the payment rates to the plans. Coding being the increased documentation that the plans are going in and capturing on enrollees to increase their overall scores because of the diagnostic coding on the patients. And you're using historical data to risk adjust going forward. I'll give you a little bit more on that in a minute. Also, is there favorable selection? You can see what happens over the years when we look at, if I'm just looking at expenditures based upon, from a fee-for-service perspective, MA being equal to fee-for-service, and then start adding on coding and adding on selection. Huge, huge difference in the reimbursements.
Yeah, those numbers should have B's after them, right?
Yes.
The $88, that would be a B.
It's not $88, it is $88 billion,
Yeah, exactly.
big, etc.
Yeah. And the idea, Kathy, just to, again, we're taking a base payment for an MA plan. We adjust that payment based on the risk in the population that they're insuring.
Right.
We measure that risk in the population using HCCs, hierarchical condition categories, which are driven by the diagnoses for those beneficiaries. So the idea here is, if you report on your claims more diagnoses, then that's going to trip up a higher HCC score, resulting in a higher payment to the plan, correct?
Well, yes, and also recognize that when we talk about that before selection and coding, we're essentially saying this is equivalent to fee-for-service payment.
Right.
Okay, and then we add on. So you can see what's happened over time. Yeah.
Exactly.
So what does MedPAC say needs to happen? First of all, there needs to be a new methodology for, there is currently an adjustment to the MA rate, unless from one year to the next, that it adjusts the payment rates based upon coding. Currently, we are looking at about a 5.9% decrease in their rates. We'll talk about rates in a few minutes, based upon coding intensity. The MedPAC is recommending that they use a model that would incorporate 2 years of fee-for-service data and MA diagnostic data. They're trying to address the fact, and they did in their March report, they actually looked at it from the perspective of, when we talk fee-for-service, let's only include those who have A and B, let's not include our A only enrollees, so that we're better doing a more comparable mix of the population to look at the distinction between MA enrollees versus Medicare fee-for-service enrollees. If the diagnoses are documented only on a health assessment and not an actual treated diagnosis, then those should be excluded, and then address a coding adjustment. Again, why would one be different than the other? That actually looks at true differences between the populations. So we'll see if this moves forward in future proposals from CMS. They also want to address encounter data accuracy and completeness. They want to replace the quality bonus program, the star rating program that is out there for Medicare Advantage, and the benchmarks themselves should be better tied to the fee-for-service benchmarks. So what happens with these? Oh, Marty, go ahead.
Well, I just want to go on the quality bonus program, the star ratings.
Mm-hmm.
we think about in the provider community, the adjustments for MIPS or the adjustments by the hospital value-based purchasing program, they're small. I mean, they're in the single-digit percentage increases or decreases in payments. These star ratings can make a significant difference in the amount that the MA plan is paid. I mean, if you're a 5-star plan, you're getting paid significantly more per beneficiary as a plan. And it's not in the range of what we see in the fee-for-service provider payment adjustments. So, and that's dollars going to the plan, not to the providers who generated that quality of care, but to the plan is receiving those.
Well, they contracted with the good providers. Never mind.
Right. That's right.
Don't be sarcastic.
Okay, rate announcement.
The rate announcement came out on April 1st. We had a preview of what the rate announcement was expected to be. And when we saw that preview of the rate announcement, they actually said there's going to be a decrease in the payment rates for the Medicare Advantage plans. Yeah, kind of. No, there is actually going to be a decrease in the benchmark payments, which are dollars that are then further adjusted by risk information. I think we probably felt when we saw the advance notice that when the final rate announcement came out on April 1st, it always comes out on April 1st, that when the rate announcement would come out, that they would have said, no, we're not really going to reduce your benchmark payments. Well,
for the 3 years prior, that's exactly what happened.
Exactly right? What they did. Now, all of a sudden, April 1st, and maybe it was April Fool's Day, that you know, maybe this is they're joking. But what they did was they actually kept that reduction in the benchmark payments. So let's take dollars down by 0.16. From a DRG perspective, think about it as your base rate that is further adjusted by a wage index that is then adjusted by the weight of the DRG. All I did in this particular case with the plans was I'm adjusting down that base rate. I'm raising everything else. All right, so I adjusted the base rate by 0.16, and the cut that the plans are getting this year is a 3.7% increase over 2024. 2023. Over 2023.
That, on April 2nd, most of the major MA players, their stock was down significantly. And this was a big deal that we were seeing what they called a rate cut. And that more importantly, what we saw was CMS, who had the schedule for MA, which is very predictable. The preview of the rate announcement always comes out at the end of January. There's a month for comment. And then this is always published on April 1st. I wish we had such predictability in the traditional Medicare space, where we think maybe we'll see IPPS proposed rule come out sometimes this month, right? This always comes out on April 1st because their proposals for the following plan year are due to CMS by June 3rd. And so they have that 2-month period to determine what their bid's going to be. And the first thing you have to know when you build the bid is what the base is going to be. So, but this was very shocking that after several years of saying, we're going to cut the rate, we're going to cut the rate. And then on April 1st, I was saying, yeah, we're not going to cut the rate. In fact, CMS did this year.
Right. There's also going to be a slight reduction in their reimbursement from the quality bonus perspective. I don't know if they're going to be blaming that on the providers or not. But everything that has come out, as Marty said, immediately after this small decrease that is really an increase, okay, was media coverage about the payer concerns about I'm not going to be able to provide the same level of supplemental benefits that I am providing now. It's going to hit the enrollees. It's going to take away things that they really need. And we actually have legislation that has been introduced by Rick Scott in Florida, which is the Protect Our Seniors Act. I happen to, because I'm in Florida, I got the little email saying, you know, support me on this. And the statement that was made was that the supplemental benefits could be reduced by up to $33 a month which is $396 a year. And we've got to stop this 0.16 reduction in the benchmark rate.
So
So
supplemental benefits that are part of the 85% of MLR, because goodness, let's protect that 15% for overhead.
it goes to overhead, and yes.
Oh.
I think it's going to be interesting, particularly if we actually see some legislation between now and later in the year that would impact the rates for 2025. We'll see. We'll see. I mean, we've got it started. Will it have traction? There is also an issue that was addressed in the rate announcement related to coding adjustments. Martie mentioned the CMS hierarchical condition categories. This is the diagnosis codes that go in to impact the Medicare and Medicare Advantage enrollees to risk adjust the payments that go to the plans. Looking at your enrollees, how sick are they compared to the typical patient, and adjust their rates from there. Would you believe that in 2024, they have now said that as we move forward into 2025, we're going to move from ICD-9 to ICD-10 for capturing this information? Major change that providers had to deal with a number of years ago, but that transition from ICD-9 to ICD-10 will go from 2024 to 2026. It'll be a multi-year phase-in. They are going to be blending the MA rates using the old risk adjustment model versus the new risk adjustment model. And that does result, excuse me, in a slight savings, $9.2 billion to the Medicare Trust Fund. And then they have also said that they are removing some codes from the hierarchical condition categories because they are not really applicable anymore, or they're better accommodated elsewhere within the program.
Yeah, and again, significant change in the model, which is all based on fee-for-service data, right? And it's CMS saying
fee-for-service.
Right, if everyone's a 1 to start at, if you have certain diagnoses, it makes you more expensive. And it's simply looking at the historical data saying, here are people with diabetes, and they are not impacting costs the way we thought they were. And so we're adjusting the model. So no one's attacking the model's accuracy. It's just, this is the result, is that we're not seeing as significant risk adjustments, which reduce the payments down. So next year in 2025, then we'll see the full implementation of this HCC model. For other CMS programs, and for example, Medicare Shared Savings Program, which calculates historical benchmarks using HCCs, and then actual spend benchmarks by using HCCs, this new model is also being impacted. So they are not moving forward to it just for MA, it's going across the board. They'll use the new model.
With that, Martie, I think we have a poll question. Finally.
Got it. Laura, take it away.
Thank you. Our first polling question is, what should happen with the Medicare Advantage program? There should be no changes, minor changes, a major overhaul, or terminate the program. Remember, you must fill out the polling question in order to receive CPE credit. You will have 30 seconds to answer.
This will be fun.
We have to have polling questions to monitor your attendance, not necessarily to gauge your opinions.
Thank you for participating in our poll. I'll hand it back over to our presenters.
Okay, you agree with MedPAC?
Exactly, very interesting.
Major overhaul.
Oops, oh. I do not want to leave the webinar. There we go, got to the right page, thank you. So let's get to the heart of the matter. What is becoming now the central conversation around MA, which is prior authorizations and utilization review. Very quickly, data, hold on a second. Data for 2021 showing using results from 87% of enrollees. There are over 35 million prior authorization requests that year, which averages out to 1.5 PA requests per enrollee. Of those, only 2 million of the requests were denied. So that's putting you at about 6.5% of PA actually results in a service not being provided to a beneficiary. Generally, providers do not appeal PA decisions, or enrollees don't appeal PA decisions. But when they do, they are very, very successful. And at 82%, either fully or partially overturning the decision made by the plan. Statistics here broken out by specific payer. You can see that there is differing utilization of PA by different types of plans. And interestingly, those are 2021 statistics. A report released just recently by the American Hospital Association showing an increase in experience of Medicare Advantage denials between January of 2022 and July of 2023, increasing by 55.7%.
I think that's why we're hearing from providers.
Exactly. So the MA plans are creating more of a process to get providers paid, and it's certainly impacting folks. So we'll quickly then go into polling question number 2.
Thank you. Our second polling question is, has your organization experienced an increase in Medicare Advantage denials over the last year? No. Yes, but minimal. Yes, significant. Provider, but does not contract with Medicare Advantage plans, and not a provider. Remember, you must fill out the polling question to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our poll. I'll hand it back over to our presenters.
Thanks, Laura. And it appears that our attendees are having an experience similar to those CFOs that were surveyed by the American Hospital Association, right, with nearly half of you saying you've seen a significant increase in denials over the last year. One more time. Sorry, every time we come out of the polling, there we go, changes. Not surprisingly, we are seeing provider pushback, and that is resulting in some changes in policy by MA plans. You'll see here on the slide some specific examples in the last year of MA plans backing off policy. The one thing that caught a lot of headlines last summer was United Healthcare announcing that they were going to do an across-the-board 20% reduction in PA requirements. Interestingly, when you looked at the list when it was published by United Healthcare, we had lots of PA requirements that were around durable medical equipment and around certain pharmaceuticals. And so really the substantive issues you deal with as providers around PA, those were not directly impacted by this rollback in PA requirements. We've seen lawsuits now emerging against MA plans, starting with the Department of Labor filing a lawsuit against United Healthcare subsidiary, against UMR, claiming that they incorrectly denied ER claims based solely on diagnosis codes. That you can't say it's not an emergency based just on a diagnosis code, that you in fact have to apply the prudent layperson's standard. This is impactful because UMR serves as the TPA for over 2,000 self-funded employer plans as well. So this has not moved forward. There's been a motion to dismiss that's been filed but not yet ruled on by the judge. A class action lawsuit also against United Healthcare was filed in November of last year, and its subsidiary Navi Health. This has been certified as a class now, though we don't have any further forward progress on the substantive issues within the lawsuit. But the allegation here is that Navi Health was using an algorithm to deny rehab care, despite their knowledge that the algorithm had a high error rate. while United Healthcare claims the algorithm is not actually used to make coverage determinations, that those are actually made by real people, that simply the algorithm informs their decision making. That gets us then to where CMS is stepping in now, and probably last year, the final rule that it made effective for plan year 2024 concerning prior authorization. So Kathy?
Yes, I think we've kind of touched on this a little bit, but we're going to go into more detail, particularly as we talk about clarifications to the rule that came out. Again, I've got to stress this was effective January of this year, although we had the rule last year. But I do continue to hear providers say the plans are saying it doesn't apply. So we're going to talk about, if you're getting those kind of comments, how you can address that. The first requirement under the final rule as it relates to coverage and utilization was, first of all, the requirement that the MA plans comply with your Medicare national coverage determinations, your local, and I stress the word local, coverage determinations, the coverage and benefits, et cetera, of fee-for-service Medicare, traditional Medicare. Going back to the previous slide that Marty had as it related to perhaps inappropriate denials for rehab care, they have to follow the coverage criteria as it relates to inpatient care, rehab, skilled nursing admissions, et cetera, home health. Remember, however, that MA plans do not have to follow the 3-day prior stay. They are exempt from that from an inpatient going to SNF. That 3-day prior stay is not applicable. That is a difference between MA and fee-for-service, but actual coverage criteria for what services can go into rehab, that kind of thing, those have to be followed by the plans. Also, a lot of discussion on the fact that the plans have to follow the inpatient only list, and they also must follow the issue of the 2-midnight benchmark, not the presumption. We're going to talk in detail about that momentarily, but they must follow the 2-midnight benchmark. If there is no Medicare fee-for-service criteria for a particular service, the plan can then go and establish its own criteria, but they can't say it's proprietary. It's got to be readily available out on their website for anyone to see, not just an enrollee, not just a contracted provider, et cetera. Anyone can go and search their website and find that information. They've got to use clinical evidence used in treatment guidelines. I'm going to go into that momentarily, but they can't just say this is our policy. Marty Ross wrote it for us. That doesn't work. It's got to be based on good information, and their policy, their criteria has to provide clinical benefits to the patient. So not just save the plan money, I guess. That was being sarcastic again. The plans are actually required to have a utilization management committee now that is led by a medical director. And they must review the prior authorization policies annually. And then we had some new rules that were just added earlier this week that says one member of that utilization management committee must have expertise in health equity. And we already mentioned, well, I guess the annual plan level health equity analysis of their policies, that must be performed as well. A great benefit to the beneficiaries and the providers that treat them is if I am in Medicare Managed Care Product A and I go to B, but under A, I had a prior authorization that had been issued, let's say, for physical therapy for a period of 3 months, and I've only been going for 1 month, the new plan is going to have to follow that previously established prior authorization. So they have to provide at least a 90-day transition. The particular document that you see in front of you is an FAQ that the CMS sent to the plans on February 6th. It's great. It is one of those documents that I urge you, if you are doing disputes or if you are doing contracting, that you have a copy of this particular document, A, where you can easily cut and paste from it, and B, maintain it always in hard copy in case your computer crashes, because you don't want to lose this. Why do I say this? All of a sudden, it's no longer on the CMS website. It's available on the American Hospital Association website. It is available on a number of websites maintained by law firms, but we can't find it on the CMS website. You put in the subject, you put in the date, you put in everything you can. We can't find this. It's about a 14-page document, but let's talk about some of the clarifications that were included. What does it mean by following 2 midnights? Okay. The admitting physician expects and documents that the patient is going to require care that crosses 2 midnights. They might not, but it was the expectation that the patient would require care crossing 2 midnights. The issue of the patient stayed 2 midnights is got to be an inpatient. No, they don't have to follow the presumption that that was appropriate. But if the expectation was documented by the physician, that must be followed. The MA plan can evaluate whether or not the expectation was reasonable and documented in the medical record, but this is a major change for providers who were constantly getting the denials from the plans because they did not cross 2 midnights, even though they were expected to. So recognize that this is a win, I think. But I urge you under that presumption to also keep a copy of this document. The other thing, and I don't believe we have a slide on it that I wanted to mention because it just came up, is there is also a great discussion of local coverage determinations in this FAQ document. And a local coverage determination is applicable in your market. It's not, I'm in Florida and I'm going to use Washington State's LCD. That doesn't work. It is what would be applicable to the patients within my community. The issue related to post-claims audits, again, addressed in this FAQ. If the plan provided prior authorization, they cannot deny for lack of medical necessity, nor can they reopen that decision without good cause. Any post-claim review that constitutes a referral to provide or pay for services would be considered an organizational determination that must be reviewed by a physician or healthcare professional with experience in treating the type of condition that is being refused or the care that is being refused.
Yeah, go ahead.
Okay, artificial intelligence. Can I use AI to make a determination about whether or not a particular service is going to be covered? Sure you can, but you're going to have to make sure that you are looking at the individual patient, their medical history. What are the physician, meaning the treating physician's recommendations as far as care, any clinical notes, and you can't use it to deny an admission or downgrade to observation. What we're dealing with here is essentially, I can't go in and just say, should a hip replacement take 5 days? I have to go in and talk about the patient and say, should it take 5 days for this particular patient with these other conditions? So I think this is a great opportunity for providers.
So in addition to addressing the substantive side of PA, CMS is also working on the procedural delays that are often part of the PA process, publishing the prior authorization final rule on January 17th. This is going to apply to Medicare Advantage plans and Medicaid MCOs. Note that this applies to goods and services and does not apply to drugs. Sort of one of the holes in CMS's strategy for approaching this. But beginning in 2026, A plan must send its PA decisions to a provider within 72 hours for urgent requests, 7 calendar days for standard requests. They will also have to furnish providers with a written explanation for the PA decision. And then later in the year, they're going to have to post on their website certain metrics regarding their prior authorization purposes. And finally, by the beginning of 2027, plans are going to need to implement APIs that will facilitate the electronic PA process, specifically providing quick access to information on what's subject to PA and specific documentation requirements that are required as part of PA. Now, this is what CMS's strategy is for these types of providers. We're seeing lots of activity in the state legislatures around PA as well. The American Medical Association had published model legislation that many states are following, but Kathy and I are very intrigued by what's going on in Oklahoma, because they have legislation running that would hold a medical director of a health plan liable for medical malpractice for improperly refusing to provide a prior authorization that results in harm to a patient. AMA did a survey in 2022 about the impact of PA on practices. Of those who were surveyed, 1/3 of the physicians said that they had an personal experience with PA that resulted in an adverse result to the patient. But I think if you go to the heart of the matter and the medical director is saying you are now responsible, if you in fact plan are saying that you are monitoring the appropriateness of services provided by physicians, and that's the importance of PA, then the person you have saying no, that service shouldn't be provided should be just as liable as the physician who said it is needed in liability. So it'll be very interesting to see what's happening down with my southern neighbor in Oklahoma. Well, what's happened with PA and the rising levels of PA requirements and the rate of denials and the slow pay, you're seeing more and more providers talking about going out of network. You're seeing more media attention to this issue, that we're seeing more provider-payer disputes being reported. And it just took a little bit of Googling to identify numerous examples of providers who are deciding to go out of network with some or all MA plans that they have. Earlier this year, HFMA published their health system CFO pain points survey, and included in that, what are your intentions with regarding MA? Or do you intend to continue to plan to contract with MA plans? 19% said they had already stopped accepting certain MA plans, and 61% were planning to do so or considering doing so for the next plan year. Wow, is all I can say to those numbers. Now, of course, this isn't just between the providers and the payers. There are also patients and beneficiaries in here. So what happens if you go out of network to a plan? Certainly, that's going to force a beneficiary to change providers if they intend to maintain their enrollment in that MA plan, except, of course, for emergency services. And that's what we see in rural areas is the rural providers don't take MA plans, but they will provide coverage for emergency services. There's also the issue of Medicare Advantage beneficiaries going back to traditional Medicare. And the issue here is Medigap coverage, because some of you that haven't been in healthcare since after the passage of the Affordable Care Act, you do not know what I mean when I say the term medical underwriting. It's the pre-existing condition. It's charging more for unhealthy patients to provide coverage to them. And we did away with that back in the ACA, except we didn't apply that rule to Medigap policies. So supplemental insurance plans can still medically rate individuals applying for their products. There is limited federal guarantee issue rights for Medicare Advantage, for Medicare supplemental plans. So if I go out of MA, I want to go to traditional Medicare and I want to go buy a Medigap policy, I'm paying twice, 3 times, 4 times what I would have paid had I been in traditional Medicare and never gone into MA. Clearly that becomes the golden handcuffs.
Because when I buy that Medigap plan initially,
yeah, it would have been the regular rate, right? Everyone's charged the same rate, but once they can medically rate you, you get charged more. There are 4 states that now prohibit medical underwriting by Medigap plans that are licensed to do business in their state. It'll be very interesting to see if we see more legislation in more states headed that direction, or even potentially federal legislation that would prohibit this one left practice of medical underwriting. Also, beneficiaries are going to have to deal with loss of supplemental benefits and higher out-of-pocket costs. So that gets us to polling question number 3, please, Laura.
Thank you. Our third polling question is your organization considering no longer accepting one or more Medicare Advantage plans? Have already done so, considering it, not considering it, or not a provider organization? Remember, you must fill out the polling question in order to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back to our presenters.
Interesting. Kind of a mixed result there by folks.
Yep. We probably should have added one more question. Wish they were considered. Never mind.
No. Let's talk about MA enrollment and marketing restrictions here in our last few minutes, because there also has been a lot of activity by CMS around this, primarily in response to beneficiary complaints. In the 24 final rule published last April, CMS imposed a number of new marketing restrictions that were applicable for the 24 plan year. And it went from everything to how you describe certain types of benefits to comparing costs and the like. So there were 22 brand new restrictions there. The rule published last month, so this is the 2025 rule that will be applicable to 25 plan year. The big news here was broker compensation. It used to be brokers could get paid add-on payments for doing certain things, which really were concerning that they were being incentivized to push certain plans over others. So now CMS has applied a flat broker compensation rate. Nothing else can be paid to brokers beyond these amounts. For 2025, that amount is $726 for every new enrollee. And for each renewal that a broker can report, they'll be paid $313. Those dollars come from the plans. There are new limitations on third-party marketing organizations' ability to share personal beneficiary information. There was a practice of TPMOs just selling and selling and selling and reselling beneficiary information. That's the reason beneficiaries kept getting repeated phone calls from different plans. Now there will have to be an explicit authorization by a beneficiary before their information can be shared for enrollment or marketing purposes, and the consent must specifically reference enrollment or marketing purposes. Beginning in 2025, plans are going to have to send to their beneficiaries a mid-year notification of available supplemental benefits. It has to be personalized. It has to notify beneficiaries, here are the supplemental benefits available to you to which you have not yet availed yourself. And in fact, we'll have to explain the scope of the benefit, if there's any cost sharing, how you can access these benefits, and a customer service number for help. So if you're going to offer the supplemental benefits, they're going to be your way to get people enrolled, then you're going to have to remind people that these are available for them to utilize. We don't have great data on utilization of supplemental benefits. That's not transparent in the MA program, but again, based on beneficiary complaints, CMS has imposed this new requirement. There's also some new beneficiary appeal rights with regard to termination of certain types of services as well. That gets us to a little gem that came out in the Federal Register back in January, which was a request for information on Medicare Advantage trace transparency. So to you, Kathy?
Yes, this is your chance. What do you want to know about MA? What do you want them to have to track? The comments on this are not due until May 29th, so you really have some time to look at this. But what information should be out there and readily accessible to enrollees, to providers who are contracting, etc., in terms of the various programs? Marty mentioned, we don't know how many of your beneficiaries or your enrollees are accessing your supplemental benefits and which ones they're accessing. Is this something we want to know? Do we want to have better scoring information related to health equity? do we want to know how many of their prior authorizations were denied? How many were requested? How many were denied? How many were overturned on appeal? What extent are those decisions being made based upon artificial intelligence, perhaps? And then are those being overturned? Lots of information that I think providers might like to know. There have been a couple of letters that have already been submitted in response to the RFI. You can find those on the Federal Register website. Some of the things that the KFF has basically said we would like to see: supplemental benefits and spending, prior auth, things I've already mentioned, timeliness of those authorization decisions. None of that information is currently reported by the plans. They do currently track and report out-of-pocket spending and payment for Medicare covered services, but that is not published. What share of Medicare Advantage enrollees reach their annual out-of-pocket limit each year? That information is captured, not published. Do you want to see it published? Is that good information in your community?
I can't believe you resisted the temptation to use the acronym MOOP, right? It's the best part of all of this discussion, right?
Sorry about that. I thought you were the only one who could use MOOP.
Okay, well, anyway, so that's a very quick and dirty through what's going on in the world of Medicare Advantage. Certainly always changing, always interesting. You see here our upcoming regulatory roundups through the beginning of June. We're going to dive into those new price transparency requirements in 2 weeks, given the deadline of July 1 for many of the changes that are going to be required for hospitals. On May 8, we'll jump into the 2025 proposed rule, assuming IPPS has been published by then, right, Kathy? If we just know the date, right?
Actually, I actually published at least 2 days prior to that date.
Exactly, at least 2 days, that's our rule. On May 22nd, Lori Foley and I are going to do a MIPS refresher course, because it seems after the pandemic, many of us have forgotten how MIPS works. So we're going to go back through the basics. And finally, on June 5th, we're going to address those new codes available under the Medicare Physician Fee Schedule for addressing social determinants of health. So we hope you'll be able to join us on one of those future events. And thanks for joining us today. Laura, back to you.
Thank you. And thanks to our presenters, Martie and Kathy. Please remember to stay on the line once the webinar disconnects to complete a short survey for CPE credit. Later, you will receive an email with their contact information and a recording of this webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete this short survey and post any questions you may have. On behalf of PYA, thank you for joining us and have a great rest of your day.